Alright guys, let's get busy talking about selective estrogen receptor modulators, also called SERMs. These have a really long name, so I will probably call them SERMs for the rest of this video. We're going to be talking about 3 different agents today, and I want you guys to specifically be focusing on the target organs of each of these agents, as well as whether they are performing agonism or antagonism, because this is going to be really important connecting to the treatments as well as the side effects of these various agents. We're going to be talking about clomiphene today and tamoxifen as well as raloxifene, and some of the target organs we're going to be talking about are the HPA axis, the bone, uterus, as well as the breast. So I'm going to go ahead and erase all these circles so that way we have a little bit more clear runway, and let's get started on this journey talking about these drugs. So let's start off by talking about clomiphene, and clomiphene is going to be a drug that we use in patients who are suffering from infertility due to anovulation. So let's get into the mechanism of action. It is going to be an antagonist of estrogen receptors in the hypothalamus. So let's go ahead and zoom in and take a closer look at this. Here is our hypothalamus. I'm going to highlight clomiphene in pink, and it is performing antagonism of estrogen receptors at the level of the hypothalamus. And we know that estrogen feeds back to the hypothalamus. So when the hypothalamus is receiving high levels of estrogen feedback, it tones down its release of GnRH. However, if we want to promote ovulation, we want to have as much GnRH, as much FSH, as much LH production as possible. So if we trick the hypothalamus into thinking there's no estrogen around, it's going to release a lot of GnRH. And that's what's happening here. So clomiphene is telling the hypothalamus, no estrogen here, and so the hypothalamus is like, ruh-roh, we better release some GnRH. So we're going to get like some big increases in GnRH from the hypothalamus, and this is going to stimulate the anterior pituitary to release luteinizing hormone and follicle stimulating hormone. And we know that these two chemicals are very potent in terms of their effect on the ovaries. It's going to lead to ovarian stimulation, and it's going to lead them to ovulate. And so if you have a patient who has infertility due to anovulation, this is going to be a great therapy for them. So let's go ahead and review this mechanism. We had antagonism of estrogen receptors at the hypothalamus. We were tricking the hypothalamus into thinking there's no estrogen around. The hypothalamus responds by increasing levels of GnRH, which is going to lead to increased release of FSH and LH from the anterior pituitary, which is going to go on to promote ovulation and help patients with infertility due to anovulation. So if a patient had infertility due to anatomical structures that were abnormal, this really wouldn't help them too much. However, in a patient with PCOS, this is going to be an ideal therapy because patients with PCOS are not ovulating, and so they produce a lot of estrogen, and the hypothalamus is sensing all of that estrogen, and as a result, it has reduction in GnRH, which is going to cause a reduction in FSH and LH, and these patients really have poor hopes of ever having a chance to ovulate. So we can kind of stick a little peg in this whole mechanism with our clomiphene and promote that ovulation. So in terms of indications, infertility due to anovulation. However, as great as this sounds in getting these patients to ovulate, it also comes with some side effects that we have to be aware of. So we're going to have hot flashes, and this is because at the end of the chain, we're going to have increased amounts of estrogen being produced by the ovary because of increase in luteinizing hormone. Additionally, we're going to have ovarian enlargement, and this is because the follicle stimulating hormone is going to be stimulating more and more follicles to grow, and people with PCOS already have huge ovaries, so this can actually be problematic and lead to even increased rate of torsion, where PCOS patients already have a risk of torsion. So this is another problem with this drug that just cannot be brushed aside. They can also experience visual disturbances and multiple simultaneous pregnancies. And this makes sense because if we're just inducing ovulation after ovulation after ovulation, there's a chance that multiple ovulations could get fertilized by multiple sperm, leading to multiple gestational pregnancies that might not even all be on the same timeline. So these are things to be aware about when we're treating patients with clomiphene. So let's move on to our next agent now. We're going to talk about tamoxifen next. And the mechanism of action of tamoxifen is going to be estrogen antagonist antagonism at the breast, and then partial agonism at the uterus and the bone. So let's go ahead and take a look at our diagram here. Tamoxifen I'm going to highlight in orange, and let's take a look at the antagonism first. So this red line represents antagonism at the breast, and then we have partial agonism, which I like to represent with dotted green lines. So partial agonism at the bone and partial agonism at the uterus. And the reason we use tamoxifen is for breast cancers that are going to be sensitive to estrogen. We know that estrogen promotes breast growth, and so if you have a breast tumor with estrogen receptors and progesterone receptors, they are going to cause increased cancerous growth in the presence of estrogen and progesterone. So the indication for this is going to be treating estrogen receptor positive breast cancer as well as progesterone positive breast cancer. And what we do here is we're essentially blocking the agonism of the breast tissue by estrogen here. And additionally, we are preserving the effect of estrogen in the bone as well as within the uterus, because we know that estrogen can be protective against degenerative bone disease like osteoporosis, and it can also help maintain normal uterine health, especially in a woman who's premenopausal and wants to have a normal period. It's going to be important that this patient has proper estrogen agonism, and this partial agonism is allowing that to still happen while having antagonism at the level of the breast. Now, in addition to breast cancer patients, we can also treat gynecomastia during prostate cancer therapy. And you'll remember in our video on prostate cancer, we talked about all the therapies relating to hormones, specifically testosterone. And a lot of that involved shunting of testosterone in different directions. So our goal was to avoid progression of testosterone to DHT, which is a really potent androgen at the level of the prostate. However, a side effect of that is that we can actually get increased amounts of estrogen, which can cause gynecomastia in men, which is a pretty undesirable side effect. So we can go ahead and give them tamoxifen to prevent this from happening. Now, just like clomiphene, tamoxifen comes with its own host of adverse effects. So with tamoxifen, we're going to have an increased risk of thromboembolic events like DVTs, and this is especially increased with smoking. And this may be familiar to you guys from OCPs, which are oral estrogens that we give patients who are seeking birth control. We always ask about smoking history because of the risk of clots with smoking and supplemental estrogen. And then these patients can also suffer from hot flashes. And then lastly, we have increased risk of endometrial cancer, and this has to do with the partial agonism that the tamoxifen has at the uterus. So you can imagine that here we're experiencing partial agonism, but everyone has different profiles of estrogen receptors. So if someone had a lot more estrogen receptors or estrogen receptors that were more sensitive at the level of the uterus, we could be giving them a lot of agonism, which could put this patient at increased risk of endometrial cancer. So that's a side effect to know about for this drug. Let's move on now to talking about raloxifene, which is going to be our last drug of the day. I'm going to highlight in blue because it reminds me of bones, which I kind of think is like a blue-white color. And I'm going to highlight it down here, and we can follow our lines of agonism and antagonism. So it's going to be an agonist at the level of the bone, and then it's going to be an antagonist at the breast and the uterus. So if we trace our lines, we'll see we have agonism out here at the bone with this green line, and then we have antagonism at the level of the uterus and antagonism at the level of the breast, represented by these red lines. And essentially, we're going to be using raloxifene for one indication on step 1, and that's going to be for osteoporosis. And I want to note that the first-line therapy for osteoporosis is usually going to be proper nutrition as well as drugs such as alendronate, which is in the bisphosphonate class. And bisphosphonates are going to be your first choice for patients suffering from osteoporosis. However, if they cannot tolerate bisphosphonates because they can cause a lot of problems with like pill dysphagia and esophagitis, you can switch to raloxifene. And raloxifene is going to help with bone health because estrogen preserves bone integrity and reduces bone breakdown. So this is going to be an option. However, it's going to come with some of the side effects associated with estrogen. So we're going to have increased risk of thromboembolic events again, especially with smoking. We're going to have hot flashes. However, in this drug, since it's an antagonist at the level of the uterus, there's going to be no increased risk of endometrial cancer. So let's do a quick recap about what's important in this video. The most important thing is realizing your target organs and whether the drug has agonism or antagonism at that target organ. The next most important thing is going to be memorizing the side effects associated with each one. But if you remember the agonism and antagonism profiles, the side effects make a lot more sense. The one side effect that's common to all of them is that they all have hot flashes, and then then the two bottom ones are going to be the ones that put you at risk of DVTs. And so a classic vignette that you may see on test day is like a 55-year-old patient who's undergoing treatment for breast cancer with tamoxifen, presenting with lower extremity pain, perhaps calf pain, and this is going to be due to the fact that they have elements of Virchow's triad. So they have malignancy, which can cause a hypercoagulable state, and they're also on tamoxifen, which we know puts them at DVT risk, and who knows, maybe they smoked a few cigarettes too, and that's going to increase their risk as well if they didn't tell you that they were a smoker, and then this is all going to concoct the perfect recipe for development of a DVT in the calf. And so this is the vignette that this type of question is trying to present, and they want you to know that there's an increased risk of DVTs in tamoxifen and raloxifene administration. So that's the type of question that you might experience on test day. I want you guys to be prepared to nail it, and I can't wait to see you guys in the next video. Bye!